Fantastic. Thanks for that, Frank. I really appreciate it. So just going to talk to you about my insights from the workers' compensation system as an occupational physician. As Frank's a very credentialed psychiatrist. He specializes in the occupational side of things as a psychiatrist, and my specialty is occupational medicine. So I'll be focusing more on the occupational side of things and maybe just sharing a bit of my observation through the system and reflecting on the current pandemic crisis that's going through and affecting everybody in our day-to-day practice and lives as well. Just starting off a bit on basics from Safe Work Australia, talking about the cost of work-related injuries and illnesses from affecting Australian employers. So we can see from the last records available that we have an increased influence and proportion from reduced capacity. So we see there's a lot of impact on the economy as such from incapacity when people are fully unfit for work or they're on long duration, but there's an increased economic burden from people who have reduced capacity, and that's where we probably work a lot more on return to work programs. And as you can see, the red color represents the workers, so most of the economic impact and the burden that we see comes across is onto the worker, and that's probably because there are direct and indirect costs as well. You see that there is an impact on the premiums, loss of productivity, but nevertheless, it's the impact on the society in green over here, and the worker on their family, on the next generation, on their livelihoods, and at what time they've had the injury earlier on or later in the career also determines the economic burden. And then the society as such takes over the toll as well with the cost of social welfare and employment benefits, disability support as well. So the picture is much bigger than what's evident on the surface. And when you look onto the after effects and the shocks afterward, you see that there's a high likelihood of chronic illness, psychosomatic symptoms, low well-being in children and families in the next generation or so, and a similar trend of behavior as well in the next generation with more psychological distress, not only in people who are unemployed or struggling, but also in the people surrounding them who are their dependents as such. And you tend to see more personality disorders in the younger generations with withdrawal anxiety and behaviors that are copied as such with substance abuse and alcohol dependency as well. So people talk about occupational medicine a fair bit. Psychiatry is well known, so occupational medicine always gets this question, what's the difference between occupational medicine and occupational psychiatry? So I thought I might just talk about that, and it's always relevant to give a bit of background of what it is all about. So occupational medicine takes a preventative approach to health and safety in the workplace, looking at how a work environment can affect a person's health and how a person's health can affect their work. The faculty is a specialty within the Royal Australasian College of Physicians. I've also been blessed that I also have had training with the Irish counterparts as well, so I'm a fellow of the Australasian and the Irish faculty as well, and I tend to compare and contrast how things work across in Ireland and Australia as well, and might be a topic for another discussion. But what occupational physicians tend to do, they act as a bridge between the health and the workplace. They act as an authority where the industry and the health providers interact, and they sort of form that bridge, I suppose. So that's why communication in return to work and rehabilitation, occupational physicians do come in a lot, and that's where I suppose my expertise come in as well, acting as a bridge between both parties, coming to terms or negotiating where the subject is the injured worker. The health benefits of work is another great document for those of you who haven't have heard of it. It's an initiative from the Australasian faculty where promotion of good work is documented in detail. It is beneficial to people's health and well-being, and that long-term work absence, work disability, and unemployment generally has a negative impact on health and well-being. there's an opportunity for you to be a signatory on this document as well. There are more than 160 or 70 organizations currently in Australia who have signed off to it. And by signing off, what you do support is that there's good evidence that work is therapeutic and it promotes recovery. It's good for you physically, socially, and financially. And time off work, if it's not medically necessary, it can delay recovery. And the longer you're off work, the less likely the chances are to return to work successfully. So those are the major points that we covered in health benefits of work. So I just want to come back to the workers' compensation system and talk about, I do assessments interstate in other jurisdictions as well. The workers' compensation system in Australia is quite specialized within its own local legislation, each state and territory, as you know. So in New South Wales, we have CIRA, Work Cover Queensland for Queensland, similar names for other states, WorkSafe Victoria, NT-WorkSafe, Return to Work SA, WorkSafe ACT, and so on and so forth. Interestingly, they follow different set of guidelines and laws and have their own local guidelines for permanent impairment assessment as well, and different insurers and local bodies sort of provide workers' compensation to workers in different states. So it's important to know what the difference is, but more than that, to know what applies to your state wherever you are. I'll probably talk more about New South Wales, as me and Frank, we practice more in New South Wales, so I'll cover that in much more detail. And apart from that, there's also Commonwealth as well, ComCare, and they cover seafarers, military personnel, and Commonwealth employees and authorities under the Safety, Rehabilitation and Compensation Act 1988 as well. So workers' compensation New South Wales, just to simplify it, CIRA is the government organization. It stands for the State Insurance Regulatory Authority. They're responsible for regulating the New South Wales workers' compensation system. iCare, or Insurance and Care New South Wales, is the New South Wales government agency that acts for the nominal insurer. And the nominal insurer contracts scheme agents to manage policies and claims on their behalf. So the workers actually get to deal with Allianz or EML or GIO insurance for day-to-day workers' compensation claims. And other than that, we get to see self-insurers and specialized insurers as well, which is a separate long list as well. So for the workers' compensation claims, just with the recent pandemic, we've had 180 claims notifications so far to CIRA as of 4 p.m. yesterday. So it'll be interesting to see. I don't have a detail of where that number comes from, but it will be really concerning to know how many healthcare workers have been affected and what the causation or the mechanism of exposure was and how was that established. But we expect that number to increase more in the future as things get more clear. But nevertheless, that's the other new update as such from CIRA, that we anticipate to see more COVID-19 cases as well. There have been changes because of the recent pandemic in regards to the guidelines as well in April 2020, which removes the requirement to obtain pre-approval for telehealth consultations. So telehealth consultation can be undertaken instead of a face-to-face for ongoing workers' compensation, or even for initial assessment and certificate, where pandemic as COVID-19 is considered as a special circumstance for this. It also affects on any permanent impairment assessments or any other binding assessments that need to be undertaken, which have been extended or postponed until a later date. So I think yesterday I was attending a telehealth webinar with ANSOM, and somehow 22nd of May came to be an important date for New South Wales. Somehow 22nd of May might be an important date where a lot of surgeries, electives, and restrictions may be lifted. So I'm not sure where did that come about, but there was a general feel about that. By the end of May, we're looking at things going back to normal. So just going back to the basics, the certificate of capacity, workers' compensation certificates are used across the different states, territories. They more or less follow a similar template, minor changes. The certificate of capacity by CERA is a common one used for CTP and workers' compensation. And I think this is a crucial legal medical document which we tend to rely on and gives us a lot of information. And we see a lot of errors over here as well as such, because of which we get referrals for IMEs and disputes. So I'll probably just go through the important aspects for us to have a look at. Essentially, we need the details across on the top as well. But the occupation job title is really important, so the doctor NTD understands what is the pre-injury duties. Signatures are of course important as well, and this is probably the segment where we see most of the dispute and conflict and confusion arise when diagnosis is relatively not clear. For example, low back pain as such does not serve as a diagnosis, rather than it's only a symptomatic indicator. And I think Frank might agree that stress itself is not a diagnosis. You know, you need a bit more than that: adjustment disorder, anxiety, or depression. But having mere stress over there doesn't give much explanation apart from simply stating low back pain as such. So using acceptable medical terminology is important for insurance agents to make better decisions. And also, even if it's a provisional diagnosis, it helps to establish the date of injury and the accident, and filling out these boxes with as much as information as possible is quite crucial in communication, because there's very little room otherwise, and we've only got a few more spaces where the nominating doctor can add their personal insight and information. Coming to the next page on management plan on the top, it should detail about the treatment, specialist appointments, anticipated physio or exercise physiology, duration, appointments, medication, dosages, and any referrals made. And then this part over here is probably something which is an indicator of basic restrictions, but doctors are able to add further details down here as well. And that's where a lot of work is done when I undertake injury management consultant reviews to negotiate return to work and increase capacities for work over here. And then some of these are quite objective and some are quite subjective indicators in terms of lifting capacity, standing, bending, twisting, squatting, sitting. But I suppose these are just indicators. The main idea is to return to pre-injury work capacity and to have a better understanding of what the role is all about. So for an office worker, these restrictions are different to somebody who's working in manual handling, who's doing heavy pushing, pulling, or deliveries, versus somebody who's working in a high management position with decision making and the opportunity to still keep on working even though they're not in office and have remote access and facilities. The comment section is something in which there's a lot of additional information at times which should be utilized, and it's an important form of communication as well. So it's important for the nominated treating doctor or the NTD to identify whether there's any pre-injury work capacity and the date when that's anticipated, and the current restrictions in terms of hours and days. And I think this is something which is not just a determination by the treating doctor, but also a negotiation between the doctor and the patient in which they've mutually agreed, or between them and the workplace as well. And if there's no current work capacity, there should be some form of description down here to say. There's always opportunity to add on a rehab provider or to make a statement if it's suitable to have additional referrals for case management. have vocational assessment or redeployment, or look at alternative positions on a permanent basis. So those kind of comments are really important. So it's really important how these certificates are filled out. For those of you who are not in New South Wales, definitely this is a bit different to Western Australia or South Australia, but nevertheless the boxes more or less are the same, and the templates are the same. They need to be signed by the doctor and by the worker with the declaration. So this segment is probably more specific to New South Wales rather than Western Australia or any other. But nevertheless, it is a multidisciplinary approach in terms of management. So the worker and employer both need to be addressed in meetings and discussions. So we don't want an employer to be left out with occupational medicine, return to work. They need to be part and parcel of the process. So that's where we see a lot of dispute happening between the worker and the employer, where the doctor-patient relationship seems to dominate, and employer is considered to be intrusive into their discussion and communication. And that's what occupational medicine is all about. It's not treating the worker, it's treating the workplace. And of course, this is all supplemented and supported by allied health professionals and workplace rehab providers under the jurisdiction of the insurance as such overall. Evidence suggests that shared goals, communication, and cooperation among the support team is critical in improving clinical and occupational outcomes for the worker. So it's important that this is undertaken overall as a multidisciplinary approach. So another thing which really stands out is when we go back to the certificates is whether the treatments recommended are reasonably necessary or not. So sometimes that's where the dispute arises, and for the insurer, it's important to address these case-by-case basis. Sometimes a reasonably necessary may be appropriate for one worker, but not for another worker in similar situation or different. So it could be an exclusive treatment for that worker in that circumstances. And the reasonably necessary has to be reasonable. It does not need to be absolutely necessary. And although there may be evidence to show a similar outcome could be achieved by alternative treatment, it does not mean that the treatment recommended is not reasonably necessary. So I suppose reasonably necessary seems to be plausible. It needs to be supported by objective evidence, but it does not need to be experimental, something which is not supported by objective evidence. It needs to be appropriate, available, with potential effectiveness recorded and documented in literature. So reasonably necessary is another dispute that arises a lot due to insufficient explanation on these certificates. And the other aspect is return to work, where I've worked a lot as an injury management consultant in trying to discuss with the NTD upgrading duties and effectively achieving a return to work, or identifying the goal, whether it's the same, returning to pre-injury employer and the pre-injury role, or changing to a different employer, different role, or same employer and a different role. So those are the other aspects of it as well. So that probably brings me towards the end of my discussion. It's pretty short and sharp, Frank. So I'll just have a look if we've got any questions over here. All right, Frank, I don't see any questions here. Might have been there, but been missed out. Did you have any comments at all to add on?
Regarding the workers' comp system?
Yeah, the workers' compensation system, that's right, yep.
Yeah, I mean, as we know, is the evolving process, isn't it? Workers' comp is among each state is different, but every state is evolving, and it's not a perfect system. There's a lot of issues within the system, but this is the only system we have, and we have to work around it. All the stakeholders, all the parties need to work around it. So, unfortunately, fortunately and unfortunately, this is a system we have to work on. But obviously, there's scope that the system is continue to evolve and continue to try to do better. And so is the insurance company. So are the benefits for the workers and the people who are injured as well, and so forth. So. So that's my opinion about the systems, and we're all trying to support everyone, with the workers, injured workers within this system, isn't it?
Yeah, that's right. Yeah, I think your presentation was quite interesting on behavior on both sides as well. And the thing which sort of stood out to me when I was working with one of these nominal insurers in the past was a lot about perception as well, whether that's true or false. And perceptions have a big role to play in terms of uh, understanding of bullying and harassment by someone in a circumstance. And it does not have to be bullying and harassment for another person, but if it is for that person, then it is technically bullying and harassment.
Yeah, and I don't know whether you're aware, but certain scheme actually accept perception as bullying harassment. So which is quite difficult. If all you need is perceived to be bully and you get accepted, then it is very hard to actually accommodate the return to work for that kind of situation. So certain schemes are not attuned to perceptions, but there are schemes who are attuned to that, which can be very difficult. But definitely perception is a common issues, and therefore sometimes therapy is about helping the individual to understand that perception and the perceived difficulties versus the reality of difficulties, um, and a lot of people, when they're injured, like from a medical issues, for example, then they become very sensitive and they tend to misinterpret and perceive dynamics differently in the workplace. So the therapy is about helping them to unpack that. Yeah.